Thank you very much, Professor Miguel. Our next speaker is Ellen Koo. Dr. Koo is Associate Professor at Bascom Palmer Eye Institute. Dr. Koo, take it away.
Yes, I will share my screen. Can you see my slides?
We can see it now.
Okay, perfect. Thank you, Dr. Soiberman, and thank you very much to Professors Basak and Professor TTL for having me today. It's terrific listening to all these talks because they are a really good segue to my next topic, which is putting it all together. It's my talk is entitled "Going Down the Refractive Rabbit Hole." I have no financial disclosures. The phrase of going down the rabbit hole was first used by Lewis Carroll in 1865. His classic Alice in Wonderland. And according to the Merriam-Webster dictionary, going down the rabbit hole means the pursuit of something, such as an answer or solution, which then leads to another question or problem or other pursuits. And so the first case describes a 67-year-old patient who underwent myopic LASIK in 1998. 11 months before he presented to me, he underwent PRK enhancement of the left eye. In that eye, he presents with corneal edema. He states his left eye is blurry, and he follows up by saying, "It's important to me that I'm 20/20 after all this. I don't ever want to wear glasses." His uncorrected visual acuity in that eye is 2150, and his central corneal thickness is 606, so thickened. His best corrected visual acuity was 2050 with high cylinder and really fluctuation and MRX whenever he came in. So what was going on? So we looked at the slit lamp exam and it showed superficial patchy corneal edema and a visually significant cataract. And anterior segment OCT really put it all together. So I diagnosed him with interface fluid syndrome, which was consistent with the history of steroid usage after his PRK enhancement. His corneal edema was persistent despite cessation of steroids and good intraocular pressure management. So we presented our case series of patients with interface fluid syndrome at the recent World Corneal Congress meeting. We demonstrated that DMAC really affords great resolution of this phenomenon. So back to our patient. Our patient had IFS with significant corneal edema, as well as a cataract that was visually significant. Again, he emphatically tells me, "I don't ever want to wear glasses at the end of all this." So what to do? So here were the sequence of events. I performed this DMAC, then waited to stabilize his biometry. So I waited about 4 months, then proceeded with cataract surgery, and he ended up 20/20 without correction. So he was happy. The second case is a 67-year-old woman with a progressing cataract. The nucleus sclerotic component had become significant. In addition, she had a significant posterior polar cataract. The posterior polar cataract is known to have abnormal adhesion to the posterior capsule. This is her preoperative exam. As you can see, the left eye cataract was visually significant. She was a moderate myope with a fair amount of astigmatism, so we discussed lens choices. Oh, again, she's adamant that she hates wearing glasses and wanted to see really well, distance and for near. So we discussed the option of multifocal toric IOL. So before I start the video, of course, when I meet her in pre-op bay, she reminds me again, she never wants to wear glasses for anything. So this is the video of the cataract surgery. So you can see it's a pretty dense nucleus. She really waited till this was really bothering her. And as you can see, there was some hydrodelineation without hydrodissection. The nucleus is carefully taken out. And when I do the IA, as the saying goes, save the best for last. So I really was trying to eat up all the cortex and avoiding that very last area of polar cataract, but it had to be done. We had to bite the bullet. So As I removed that last bit of cortex, I could see was continuous was the posterior capsule, fill it viscoelastic. Hey, my bag is still intact. So you know what? I'm going to go for it. I'm going to put in my lens that I chosen, put in my suture, and gently, by making another paracentesis, I'm switching to bimanual to take out the little bit of cortex that's left. And all the while, you know, the main thing is to maintain a deep chamber so you do not have vitreous prolapse. And at the end, I'm just taking out the remaining viscoelastic. And, you know, I want to emphasize the biggest thing is to, when you take out your bimanual, to make sure you hit the AC with infusion as you withdraw your infusion handpiece. So this maintains a chamber without vitreous prolapse. And so everything went really nicely. She was happy with her outcome. This third case, this is a 65-year-old woman who travels several hours to come see me for a second opinion to improve the vision of her right eye. She had previously undergone a PK, and she felt the vision had been gradually worsening. What was going on? So the best corrected visual acuity with spectacle correction was 20/60 in that eye. The slit lamp exam revealed a raised corneal lesion right at the graft-toes junction. Temporally, you could see the elevation, that hazy white stuff. So I diagnosed her with ACHD, acquired corneal subepithelial hypertrophy. So this corresponded to marked steepening on topography. So I performed a superficial keratectomy. Now, these things do really peel off very beautifully. And so after I got rid of the lesion, she had marked improvement of her clinical exam, as well as her vision at 1 month. Her vision was 20/30 with spectacle correction. And the topography shows improvement as well with better overall symmetry. So I thought that was a win. I thought we were done, but she goes, can you do more? So looking at the topography, although I've improved the overall asymmetrical astigmatism, she still had nearly 8 diopters of symmetrical astigmatism. So I turned to one of my favorite tools of the trade, the compression suture. After placement of compression sutures, you can see that she had marked improvement of cylinder and manifest, -8, cylinder of 2 at excess of 10. So again, I thought we were done. And really, you can see the marked improvement of the topography. The left is before and the right is after the compression suture. But she asked me, can you do more? I hate wearing a contact lens in just one eye. You have to keep in mind her other eye was almost emmetropic, so she had to wear a contact lens to avoid anisometropia. So we proceeded with PRK with mitomycin. And this is her topography 6 weeks after PRK. As you can see in the image, the astigmatism is now less than 2 diopters. And her manifest refraction shows a wonderful result. So the conclusion is, journey down the rabbit hole can be fulfilling and satisfying to the patient and surgeon. As corneal and cataract surgeons, we're in a really unique position to design a customized plan for the patient with tools in our toolbox, using a combination of corneal surgery, refractive surgery, and cataract / lens-based surgery. And yes, we absolutely can. Thank you so much.
Thank you, Dr. Koo. Those Florida patients are very